Well, good morning, everyone. We are very excited to be hosting this webinar with the Lucile Packard Foundation for Children's Health on improving pediatric to adult healthcare transitions in Medicaid, MACPAC's recommendations to Congress. So thank you all for joining this webinar today. Next slide, please. I want to offer some brief introductions to our speakers and then have Holly do a welcome, and Lynn Jennings and Ava Williams from MACPAC will present, and then we'll have time for questions and answers. And if you could please put your questions into the chat and we will discuss at the end of the webinar. So I'm delighted to welcome Holly Henry, who is a program director at the Lucile Packard Foundation for Children's Health. Holly works with grantees and partners focused on improving healthcare systems for children and youth with chronic and complex needs and their families. She is a social and behavioral scientist whose work improving children's health has included international and domestic research studies on obesity prevention, media use and awareness, HIV prevention and tobacco marketing, as well as state and federal policy. Dr. Henry received her master's in health sciences and PhD at Hopkins Bloomberg School of Public Health and is the very proud mother of 3 children. And I want to acknowledge Holly's leadership and support for this webinar and for the work of God Transition. Our next speakers are from the MACPAC. I'm going to start with Lynn Jennings, who is a senior analyst on the Access team and has worked at MACPAC for over 4 years. At MACPAC, they have worked on a variety of projects, including Medicaid demographic data collection, the annual MAC stats report, and the Medicaid access monitoring system. Lynn also leads the work on children and youth with special healthcare needs and their transitions to adult care and coverage. Before joining MACPAC, they worked as a budget and policy analyst at the Wisconsin Department of Health within the Division of Medicaid. They have a master in science in population health with a concentration in health services research from the University of Wisconsin-Madison. And Ava Williams is an analyst on the Access team and has worked at MACPAC for the past 2.5 years. She has worked on a variety of projects, including children and youth with special needs and their transitions to adult care and coverage. Also, she's worked on projects related to access to care for justice-involved youth and the annual MACPAC stats report. And before joining MACPAC, she worked as a research assistant focusing on suicide demographics in the Miami-Dade County area. And she has a Master's of Art in Forensic Psychology from the George Washington University. I'm very delighted to now turn it over to Holly for her welcome. Thank you.
Thank you, Peggy, and welcome everyone. It's so great to see so many attendees here, especially on a Friday in the summer. I think it speaks to the importance of this topic. Again, my name is Holly Henry. I direct the program for children and youth with special healthcare needs at the Lucile Packard Foundation for Children's Health. Our work focuses on improving the healthcare system for children and youth and their families. And a key aspect of our work is ensuring that as these children and their families grow and develop and age into adulthood, that the system is prepared to continue to meet their needs. We know that this is not often the case. It seems appropriate today to just acknowledge I have our Disability Pride Month flag behind me. It's July. This is an important time to remember and recognize the needs of people with disabilities. I also think it's more vital than ever for us to be thinking about how children and families are going to move, particularly through the Medicaid and CHIP system in this time when the programs are under so many constraints and upcoming budget cuts. So I'm thrilled to be joining our partners today at the National Alliance and God Transition, as well as the MACPAC to learn more about their new recommendations to address healthcare transition for youth with special healthcare needs. We're so grateful to Got Transition for their leadership, as well as for informing the work of the MACPAC. Oh, that's a hard word to say. The MACPAC. And just really pleased that you've chosen transition from pediatric to adult care as one of your key priority areas. So with that, I think I'll turn it back to Peggy. Thank you.
Yes, thank you, Holly. And that's an understatement, how delighted we are that MACPAC selected healthcare transition as a priority. So without further ado, I'll turn it over to Lynn and then to Ava.
All right, well, thank you so much. And really thank you to the Lucile Packard Foundation and Got Transition for hosting this webinar today. We're excited to present our chapter and recommendations on children and youth with special healthcare needs and their transitions from pediatric to adult care, which were published in MACPAC's June 2025 report to Congress. Next slide. And so before beginning our review of the chapter and recommendations, I just want to provide some background on MACPAC and the agency and the Commission's work and recommendations. And so MACPAC is a nonpartisan legislative branch agency that provides policy and data analysis and makes recommendations to Congress, the Secretary of HHS, and states on issues affecting Medicaid and CHIP. And MACPAC serves as an independent source of information on Medicaid and CHIP and publishes issue briefs and data reports throughout the year to support policy analysis and program accountability. MACPAC has 17 commissioners, and they come from diverse regions across the United States and bring broad expertise on a wide range of perspectives on Medicaid and CHIP. And just as some examples of our commission and their former roles as former Medicaid directors. We also have commissioners who are executive directors of managed care plans and hospitals, pediatricians, and one Medicaid beneficiary. The commission publishes 2 reports to Congress each year with a series of chapters on work that has been completed and on work that has led to recommendations. And so during each of these report cycles, staff present findings on ongoing work to the Commission during 6 public meetings that occur between September and April. And during these meetings, staff present to the Commission our evidence-based findings from the policy work. And also during these public meetings, there is time for public comment. The Commission discusses during these meetings findings and provides input on the direction of the work. And this can also include discussing possible policy recommendations to address issues that are identified. And if the Commission believes the evidence supports recommendations, they vote on recommendations that can be directed to Congress, HHS, and states. And so for the past 2 Commission cycles, we have presented findings on our work on children and youth with special healthcare needs and their transitions from pediatric to adult care. And so today I'll present, Ava and I will be presenting findings from our chapter and these 4 recommendations. And so next slide. So today we'll start with an overview of the project, aims, and methodology that we use to conduct this work. And then I'll provide a summary of our chapter, which includes a brief background on children and youth with special healthcare needs, current federal requirements, and the state Medicaid and Title V roles in supporting these transitions. I'll also review the key challenges that we identified with the transition of care process for Medicaid-covered children and youth with special healthcare needs. And then Ava will present our recommendations and rationale, and then I'll conclude with some of our next steps for this work. Next slide. So our study had 3 primary aims. 1, to examine how state Medicaid programs and managed care organizations operationalize their children and youth with special healthcare needs transition of care policies. We also wanted to understand the beneficiary and family experience during this transition. And we also wanted to identify barriers to transition that could be addressed in federal Medicaid policy. And so to address these aims, we conducted a literature review, a federal policy scan, a state policy scan, stakeholder interviews with federal officials, 5 state Medicaid agencies, national research experts and advocates, and state-level advocates in the 5 interviewed states. We also conducted 4 beneficiary and family focus groups with participants who were either currently going through the transition or had previously completed the transition to adult care. We also conducted an analysis of the 2022 National Survey of Children's Health and published findings in an issue brief, which is linked on this slide, but also on our final slide with the QR code. And so for this work, we also contracted with APT Global, and they conducted the federal and state policy scans, the interviews, and focus groups in collaboration with MACPAC. Next slide. So almost 1 in 4 children have special healthcare needs, and almost half of these are covered by Medicaid. Children and youth with special healthcare needs can also receive services and supports from state Title V agencies. And as children and youth with special healthcare needs approach adulthood, they need to transition from pediatric to adult care. And this is a multi-step process that often begins several years prior to the child aging out of pediatric care. And research shows that individuals who receive a structured transition, which includes a transition of care plan, have better health outcomes. However, our findings from our analysis of the National Survey of Children's Health indicates that many children and youth with special healthcare needs do not receive transition services or a transition plan. And also, although there are known challenges with this process, there are a few data sources that collect information on children and youth with special healthcare needs, and even fewer that collect consistent or comparable data for assessing the size of this transition age, Medicaid covered children and youth with special healthcare needs population, for assessing who has a transition of care plan, how many transition to adult providers, and health outcomes and service use after transitioning to adult care. Next slide, please. Medicaid statute and its implementing regulations don't include requirements for children and youth with special healthcare needs and their transitions from pediatric to adult care. There are, however, expectations for states to provide transition planning for beneficiaries enrolled in Section 1915C HCBS waivers that have age limits. There are also some provisions of the federal Medicaid care rules that address issues related to access to care for beneficiaries with special healthcare needs across the lifespan. Though I want to note that these provisions don't directly relate to the child to adult transition of care. CMS has also published some guidance related to these transitions. For example, recent EPSDT guidance specifies that care coordination and case management can be used to facilitate the development of a plan and outline the transition process to appropriate providers and services. The Maternal and Child Health Bureau, MCHB, within HRSA also funds state Title V programs through the Maternal and Child Health Services Block Grant Program, and state Medicaid and Title V agencies both serve children and youth with special healthcare needs, and they are required to coordinate with each other. Each state Medicaid agency must describe a cooperative agreement with the state Title V agency, called an interagency agreement, or IAA. And the IAAs must specify certain information related to the roles and responsibilities. And they're important for ensuring close collaboration and clear communication. And they should outline coordination efforts for children and youth with special healthcare needs, such as coordinated care and case management. But states are not required to specify roles and responsibilities related to the transition from pediatric to adult care. Next slide. So now going on to the state role in the transition. So state Medicaid agencies have the flexibility to define their own transitions of care strategy. And in these next couple slides, I'll highlight some of the key findings from our state policy scan and our state stakeholder interviews. And so first, states can define the children and youth with special healthcare needs population for their programmatic purposes, and the definitions may vary depending on the specific eligibility pathways, waiver authorities, and state plan options. State Medicaid agencies and MCOs both have a role in identifying and notifying those approaching transition age and specifying who is responsible for providing these transition services. And in our review of state 1915C waivers, we found that the time beneficiaries and caregivers are notified in advance of a transition varies by state and sometimes by waiver within a state. Almost all states include some information about transition planning in their waivers, but the transition planning procedures and level of specificity does vary. So for example, some waiver applications specify services to support the transition of care and who is responsible for supporting the beneficiary through this transition, but not all specify the development of a transition plan. Many states also include provisions in MCO contracts related to transitions of care, but in our review of MCO contracts, we identified a few that include provisions to specify who is responsible for the transition of care and the development of a transition of care plan. However, we will note that in states that have specialty managed care plans for children and youth with special healthcare needs, the contracts do include more specificity. Next slide. And so for coverage of services, there are no federal restrictions on states covering services to support transitions of care. And these services can be provided as part of care coordination and targeted case management. These services may also be provided through state plan and waiver authorities, but states may not always be aware of how to cover them through these existing authorities or which existing CPT codes apply. Related to data collection, CMS does not require state Medicaid programs to collect or report data related to the transition of care for children and youth with special healthcare needs or their health outcomes after the transition. So most states do not collect these data. However, some state agencies and MCOs may collect quality data that captures some of this information related to children and youth with special healthcare needs. Related to collaboration with Title V, state Medicaid agencies, as I said earlier, are required to establish IAAs with Title V agencies, but they aren't required to specify the roles and responsibilities for supporting the transition of care. In our review of all IAAs, 4 states included information specifically on the transition of care. Next slide. So findings from this work indicate that there are 5 primary challenges to children and youth with special healthcare needs transitioning to adult care. And so first, there's no federal requirement for states to document or publicly communicate their transition of care strategy for children and youth with special healthcare needs. And findings from our family advocate interviews and beneficiary and caregiver focus groups indicated that beneficiaries and their families found this transition process confusing and frustrating because they weren't always provided with clear expectations about the transition of care. And they were unable to locate state resources or a documented state strategy with explicit steps. And finally, they were also not aware of who was responsible for supporting them through this process. Second, there is no federal requirement for states to develop a transition of care plan for each child with special healthcare needs. But research does show that these plans are important for improving outcomes related to the quality of care, access to and use of adult care services after the transition, and continuity of care and coverage. Beneficiaries and families with transition of care plans shared in our focus groups that care plans were helpful if they laid out specific transition steps, including addressing how to identify adult providers, and were updated as the child aged and their needs changed. However, in most cases, the transition of care plans they had did not address many of these components, and many families share that they did not have a designated person to help them through this process. Third, there's a lack of guidance to states on coverage of services to support these transitions of care. And so through our work, we found that some states do cover transition-related services using existing authorities such as targeted case management, but there was a lack of awareness by states on how to use these existing authorities. The lack of guidance to states on covering transitions of care services and to providers and professionals on how to bill for transition services can be a barrier to ensuring providers are reimbursed for providing these services. And finally, there's a lack of data collection on transitions of care. There's no federal Medicaid requirement to collect or report these types of data, and state Medicaid agencies generally do not collect data about children and youth with special healthcare needs and these transitions. Findings from our work indicate that there's a need for collecting these types of data to understand how current state transitions of care strategies are serving children and youth with special healthcare needs, if there are gaps in access to services, and the effect of transitions on health outcomes. And there's also a lack of cross-agency coordination between state Medicaid and Title V agencies. State Medicaid and Title V agencies, as I said earlier, are not required to coordinate on the transition of care for children and youth with special healthcare needs. And due to this, few state agencies coordinate on these, or in their IAAs specifically identify that they coordinate on these transitions. And there aren't always clear expectations around which agency is responsible for supporting them through this transition. And now I'm going to hand it over to Ava to present our recommendations.
Thanks, Lynn. Now I'm going to go over the recommendations and rationale. I will also be discussing implications for these recommendations at the federal, state, and local level, including for beneficiaries and providers. The first recommendation states that Congress should require states to develop a strategy for transitions of care for children and youth with special health care needs that includes an individualized transition of care plan the entity responsible for developing and implementing the individualized transition of care plan, timeframes for the transition, and making the state strategy publicly available. This recommendation has a minimum population that includes children enrolled in Medicaid through SSI, the Katie Beckett eligibility pathway for children with disabilities enacted under the Tax Equity and Fiscal Responsibility Act, also known as TEFRA, those enrolled in a Katie Beckett waiver, and those who qualified to receive an institutional level of care. Next slide, please. Our research found that having a structured transition strategy that includes an individualized care plan improves transition outcomes. We also found that few states have a documented transition of care strategy for children and youth with special health care needs. Under this recommendation, states have the flexibility to determine their transition strategy, including what services to cover based on their children and youth with special health care needs population, delivery system, and program design. The chapter notes several considerations for states when developing their strategies, such as expanding on the minimum population detailed in the recommendation, leveraging existing frameworks for transitions as a foundation for their strategies, engaging and soliciting feedback from stakeholders, beneficiaries, and their families when developing their strategies, the importance of engaging adult providers in the transition process, as well as reviewing and updating the care plans on a routine basis. Next slide, please. For each of the 4 recommendations, the Congressional Budget Office does not estimate there will be a direct effect on federal spending. States will need to allocate resources to develop and document their transition strategies, as well as establish parameters for individualized transition plans. Beneficiaries and their families would have a better understanding of their state's transition strategy and expectations for their own transitions. Plans would have a better understanding of the state's transition strategy and expectations for how they should support this population. Lastly, providers may be involved in developing individualized transition plans. Next slide, please. Our second recommendation states that the Secretary of Health and Human Services, HHS, should direct CMS to issue guidance to states on existing authorities to cover transition of care related services for children and youth with special health care needs using the same minimum population as the first recommendation. Next slide, please. Stakeholders indicated a need for guidance on claiming for transition-related services, capitation rate setting that accounts for these services, and opportunities to cover interprofessional consultation, as well as information about opportunities for providing transition-related services under targeted case management, also known as TCM, and the EPSDT benefit. The chapter also notes that CMS should consider addressing how states can cover warm handoffs and same-day visits between pediatric and adult providers, as well as other activities that facilitate transitions. Next slide, please. If this recommendation were to be implemented, states would have a better understanding of how to use existing authorities to pay for transition-related services and would need to make payment policy changes. Beneficiaries, their families, and caregivers may experience increased access to transition-related services and supports. Plans may need to implement provider payment changes, and providers may receive payment for services they previously have not been, and engage with children and youth with special health care needs earlier in the transition process. Next slide, please. The third recommendation states that the Secretary of HHS should direct CMS to require states to collect and report data related to if beneficiaries receive transition-related services, including the receipt of an individualized transition of care plan. Additionally, states should collect and report data related to the beneficiary and caregiver experience with transitions of care. Next slide, please. Through our work, we found that a lack of transition of care data limits CMS, state, and other stakeholder understanding of the extent to which children and youth with special health care needs receive transition of care services, as well as areas for improvement. This recommendation is focused on improving data collection and reporting related to the transition of care process, including the number of children and youth with special health care needs receiving transition-related services, what services they receive, and if they have an individualized transition of care plan. The chapter includes considerations for CMS in implementing this recommendation. For example, CMS should solicit input from stakeholders, including beneficiaries and their families, on what information would be most meaningful to collect to better understand this population and their transitions of care. CMS should also leverage existing data collection activities to prevent duplicative efforts and consider collecting information related to the adult system after beneficiaries transition. Additionally, the chapter acknowledges that evaluating health outcomes for this population is challenging, and more work is needed to develop meaningful health outcome measures that capture information about the experience during and after the transition to adult care. Next slide, please. Depending on the extent to which states leverage existing data collection efforts, they may not have to collect additional data to meet reporting requirements. Stakeholders would have a better understanding of beneficiaries and their families and caregivers' experience with transitions, and in turn, how to improve transitions. Similar to the state implications, depending on the extent current data collection is leveraged, plans may not have to make changes to their collection efforts, and providers may have new reporting requirements related to the receipt of an individualized transition plan and gain a better understanding of this population and their transitions. Next slide, please. The last recommendation states that the Secretary of HHS should direct CMS to require that state Medicaid agencies, IAAs, with state Title V agencies specify roles and responsibilities for supporting children and youth with special healthcare needs transition from pediatric to adult care, and that the state Medicaid agency's role described in the IAA should reflect the state's transition strategy. Next slide, please. Few state Medicaid and Title V agencies coordinate with each other on agency roles and responsibilities related to children and youth with special health care needs transitions of care. This recommendation focuses on requiring state Medicaid agencies to specify in their IAAs with Title V which agency is responsible for providing which transition services, developing pertinent training and educational resources, and providing other supports to facilitate transitions for this population. Additionally, although this recommendation is specific to state Medicaid and Title V agencies, states should consider engaging and collaborating with other agencies that provide services and supports to children and youth with special health care needs, such as departments of developmental disabilities and education agencies. Next slide, please. If this recommendation were to be implemented, state Medicaid and Title V agencies would need to update their IAAs to meet new requirements. Beneficiaries, their families, and caregivers may experience more coordination and support from both agencies. Plans may need to collaborate and coordinate with state Title V agency on services and supports for this population transitions, and providers may experience changes to their roles in supporting children and youth with special health care needs during their transitions. Thank you. Now I'm going to turn it back to Lynn to go over the next steps.
Thank you, Ava. So before wrapping up, we just wanted to share that we are working on the second phase of work, which is focused on the Medicaid coverage transition, so from child to adult Medicaid. And so throughout our first phase, we really heard from stakeholders and beneficiaries and our commissioners about the importance of also examining this transition between child and adult Medicaid coverage, and also considering how this might relate to the SSI redetermination at age 18 and transitions from a child-only waiver to another waiver available in the state. And so we are still conducting the policy analysis this summer, so we can't share any findings at this point, but we just wanted to note that we will present our findings starting at our September commission meeting. And just for you all, just to note that we do have links in the slides to our chapter and recommendations in our report to Congress, and also a link to our Access and Brief, which is the brief that uses data from the National Survey of Children's Health. So thank you very much.
Well, Lynn and Ava, thank you. That was a tremendous presentation, and I think it's fair to say that this is a groundbreaking report and set of recommendations for our field. And we very much appreciate the level of comprehensiveness and commitment to both the challenges and also coming forward with some much needed practical recommendations. To also imagine that you're going to continue down this pathway around transitions of coverage, I think makes us all so very happy. So thank you so much. Now I'm going to turn it over to Patience, who's handling the chat, and Annie, who's handling the Q&A. And then we have a few discussion questions we'd like to get to as well. So thank you all.
Great, thank you, Peggy. Actually, most of the questions are sitting in the Q&A. People thanked Holly and Peggy and MACPAC folks for this report, and they thought it was well done. So I guess I turn it over to Annie, who has some of the Q&A questions.
Great, thank you. So I'll just go in order of these questions. The first one that was asked was, would the pediatric to adult transition be less of a problem if there were more emphasis on family practice instead of pediatrics?
And Patience, you should feel free to hop in on that call. Don't want to put Lynn and Ava on the spot.
Well, thank you for the question. I think I'm not quite sure the emphasis here. In a sense, there's a problem in getting into the adult healthcare system, no matter who the provider is, because of the lack of supports. If we had that, I think that's really the issue here. It's not so much which provider. There are also lots of problems with finding primary care providers, no matter whether they're family practice, internal medicine, or med peds. So I'm not sure changing the emphasis on the type of provider is going to allay much of this problem as we see it coming forward in the next many years. But thank you. I hope that answered your question. I'll turn it back to Annie, unless somebody else wants to add. Lynn, Ava, or Peggy, or anybody? Great. I'll turn it back to Annie. Thank you.
Yeah. So the next question was just whether targeted case management requires a CMS waiver. So is that correct in order to get reimbursement?
Yeah. So my understanding is that targeted case management could be covered through the state Medicaid plan, but that maybe in some states they would choose to offer this through a waiver. But we can also take a closer look at that and get back to you.
Okay. Yeah, and we can send a follow-up email with these questions that have been asked. If any of them don't get answered, we can send responses. So the next question was, what recommendations have been taken up into the Reconciliation Act, HR 1? And for any recommendations that have not been taken up, is it known where they exist in the legislative bill life cycle?
That's a really interesting question. So the commission's role is an advisory board to Congress and other federal partners. We cannot speak to whether Congress, CMS, or states will implement the commission's recommendations, but we do hope they will. We do track if recommendations are taken up either fully or partly, and this is put up on our website. Lynn, do you have anything else to add to that?
Yeah, just let's see, or the question was just kind of if it was, I guess, if any of these recommendations also are currently in the Reconciliation Act, and I'm not aware that so we have one recommendation that's directed to Congress, and I'm not aware that that was included in the Reconciliation Act. But as Eva said, we do track our recommendations, and that's available on the website. And we can also, I can find that link and make sure that it gets shared out.
Okay, and so you just answered part of this question, but has the current HHS secretary commented on or acted upon any of these recommendations? And if not, could we be educated on how recommendations will be considered and what the public's role is in that process?
No, I don't believe the secretary has commented on any specific recommendations. What we do know is that we send a report to Congress on the 15th of March and June every year. We give these reports mainly to the Senate and Finance Committee, as well as Energy and Commerce on the House side. We will have conversations with them with our partners. When needed, they can ask us for TA and other things, but the actual process of how these recommendations would be implemented, we are unsure.
Okay, thank you. So the next question is, will these recommendations apply for individuals who are disenrolled from Medicaid at age 19, or shortly after due to changes in eligibility? Given that eligibility changes at adulthood and disenrollment increases, this person is curious whether and how transition planning would account for this potential loss of coverage.
Yeah, so in terms of, so we are looking a lot like at the eligibility piece in our new work, but in terms of the transition of care, our kind of role and scope is really on Medicaid. And so we focused really on like the transition of care, I guess for those who are Medicaid or CHIP covered. I think in terms of the transition planning, a number of waivers in kind of like our state scan of 1915C waivers do address transition planning and attempts to help with if there is an expected loss of coverage or loss of services, other avenues. But I think that's at most what it would kind of apply in terms of the transition planning. Hopefully that helps answer the question.
Okay. So the next question is, understanding that this work is focused on Medicaid and CHIP, regarding data collection and the implementation of outcome measures or quality measures, to what extent do you think there would be alignment with Medicare? Would the recommendation for collecting data be strengthened by recommending CMS have transitional care quality measures?
I can start, but also Ava, feel free to add. So for our, I guess the scope of work, we didn't look at Medicare data. So unfortunately, I don't know if we could really speak to whether the recommendation would be strengthened by that, just because it wasn't something we specifically looked at. But that's certainly an interesting point and something to think about.
I think the only thing that I would add is that in the chapter, we did note for CMS that they should try to leverage existing data collection efforts. So if any way that data that's collected for Medicare can be used for this data collection, I think CMS can definitely look at that.
Okay, so the next question, is there work being done around Medicaid approved adult providers willing to accept and take on medically complex young adults?
We do not currently have work on that. MACPAC has a range of work on different provider issues, but I don't believe we currently have work on that. Correct me if I'm wrong, Lynn.
I think you're right. Yeah. That we don't have anything currently any current work on that.
Okay. Next question, could the further research also consider whether and how expanding coverage of Title V to age 26 would help facilitate transition? This individual's hypothesis is that this is a key policy approach that could ease the transition.
This is definitely an interesting question, and thinking about kind of other ways to ease the transition. For purposes of our work, and our recommendations really can just be like the scope is on Medicaid and CHIP, and so we wouldn't really, I guess, focus on kind of specific recommendations that would be directed towards Title V or any other agencies. But I agree that this is an interesting question. And I don't know if Ava has anything to add.
Could I just jump in on that one? I think from the perspective of Medicaid, the Oregon plan, the Oregon State Medicaid Agency has an approved waiver to extend the childhood age and EPSTT up to 26. And again, with the hopes that it would be helping to facilitate a more continuous process. But to my knowledge, that's the only state. And that's not a Title V answer.
Okay, so the next question is, are there ways we can advocate for these recommendations to be implemented, particularly in the current larger landscape with anticipated changes to Medicaid? And this person also just thanks you very much for your time and energy to this important area.
Yes, I think personal advocacy is perfectly fine. We directed these recommendations to CMS and Congress because we felt that federal partners were the best positions to help and to solve the problems that we identified. But for example, CMS has the ability to set minimum requirements for states, but also allows flexibility. But there is nothing prohibiting states from implementing these recommendations. Lynn, would you have anything to add to that?
Okay, so the last question in the Q&A is, do you have any information about coverage for transition planning from private insurance plans?
So we're still, I guess, in process with our work on coverage transitions, but we are, for that work, really focusing on the transition from Medicaid for those under 19 and maintaining Medicaid as an adult. And so we haven't really looked at that other kind of transit if you're coming from private insurance or other insurance. So unfortunately, we don't have anything we can share on that.
Okay, and Patience, I don't know if you wanted to add something, you just went off mute.
Yes, so we have one more. We have a question that's sort of in line with some of the questions that have been going on in the Q&A. This person says, great presentation. As a global patient advocate, I would like to know, can your findings help facilitate more state-to-state planning and implementation of universal transition services so we can give patients and families leverage for best outcomes? Do you see future alliances being formed to reduce fragmented healthcare services from childhood to adulthood?
I think our recommendations can be used for that. Several of our considerations in the chapter is about states collaborating with other agencies outside of Title V, so like education agencies or developmental agencies to streamline processes. And I'm forgetting the first part of your question. Can you repeat it, Patience? Or Lynn, if you remember, can you answer?
It was really help find us to facilitate more state-to-state planning and implementation of universal transition services.
Yes, I believe so. One of the considerations is for states to look at existing transition of care frameworks and allow for collaboration with that. Lynn, do you have anything to add?
I don't think so. I think you're right that our recommendations and the findings from this certainly could be applied. And there are, as Ava, I think Ava mentioned, many different considerations for how states may be able to do this. So I think, yeah, I don't have anything specific to add. I think there's certainly opportunities there, but isn't something that we specifically focused on in our findings.
Yeah, I'd like to just also put a plug that Got Transition works very closely with the Packard Foundation and also the National Center for Systems of Care for Children with Special Needs. And we're going to be continuing conversations about how to elevate this report and get it out to more advocacy organizations as well as state Medicaid officials. So I just wanted the audience to know that as a National Resource Center, we want to keep pushing this since we've got a golden opportunity, though the timing is a crazy time, but we're excited to have this potential.
Okay, and some questions are continuing to come in. So I can keep going unless Peggy, you wanted to ask any of your questions.
Let me just plunk in a couple questions. I want to underscore what Ava and Lynn said about that state Medicaid agencies can adopt these without congressional authority or without CMS guidance. So I just want to be clear that you've opened the door to a larger world of some policy options here. And I just wonder from the standpoint of next steps with Congress and CMS, do you have like a presentation or something that you do, or how do they formally respond to your recommendations?
So once we publish the report and recommendations, they are delivered to Congress and shared with those who we direct the recommendations to and made public on our website. But in my understanding that is kind of, at that point, we wait and we see to see if things get if any of the recommendations are implemented. We don't have any formal conversations about them.
Yes. Thank you. Another question I wondered about what surprised each of you the most about the transition policy and service gaps affecting those with chronic and disabling conditions.
All right, I can start, and then so for me, I think one of the, I guess, most interesting and helpful parts of this work was really having the beneficiary and family focus groups. And I think one of the challenges that really stood out across those conversations was the challenges that they had with identifying a case manager or a care coordinator who really understood the unique challenges and unique steps of the transition from pediatric care to adult care, and how that is a different transition from others that might happen within the medical system. And they also really, one of the key challenges with this is that they often couldn't find a care manager who really understood that. And because they didn't understand that process, they did the educating. And really the burden was on the family to do the educating of that care coordinator. So that was one of the findings that really stood out to me and really illustrated some of the challenges with this, with the transition. And I'll hand it over to Ava.
One of the things that I found most interesting was the amount of support that beneficiaries and their families receive from the school system. So over and over again, we heard that the school system provides healthcare, education, employment, and social support for these families, and that these families and beneficiaries receive a lot of resources and outreach about upcoming transitions from schools and teachers, and how, as a child reaches adulthood and loses that support system in schools, that can make it even more difficult for them as they transition their employment, transition their social and friendships, transition to school, transition in general.
Well, thank you. I'm just going to turn to Annie and Patience to see if there are any other closing questions.
Not in mine. Annie, you have a few more.
Yes, there are some more. So the next question was, are you aware of any structured transition programs in use by care teams today with patients in a particular disease state that are receiving coverage or reimbursement for time spent on transition education? And if so, can you name the program or disease state?
I don't think I have specifics, but throughout the project, we did hear that specific clinics that focus on specific diseases more than likely have a more structured transition approach for their beneficiaries. It's slipping my mind which this was, but it was for specific diseases. Can you remember any, Lynn?
No, I was having a hard time remembering. I think, yeah, they came up in some of our interviews as kind of just examples to look to. But this may also be a good question for Peggy or patients in thinking about some of the standards for transitions.
Patience, I'll turn to you.
Well, there are many actually. So this anonymous attendee, what I'd love to have you is send me an email, you know, phwhite@thenationalalliance.org, because I'd be happy to fill you in. Certainly, Lynn Vogel mentioned one at Nationwide Children's in neurology. So there are quite a few in neurology. There are quite a few in rheumatology. There are some in sickle cell disease. And somebody who answered on these calls, Stephanie Pratt, where she's working at Mercy Children's Kansas City. They have it throughout their whole outpatient department. So feel free to email me, and I'd be happy to connect you with quite a few once you sort of narrow down, if you'd like, a little bit where you're interested. So I think there's a lot happening across the country. The second part of your question is getting reimbursement. Well, we do have, and we're updating a toolkit around reimbursement for transition services, but you also have to negotiate a little bit about getting some of these codes covered in a particular setting. And we're working with some states doing this, and for instance, in Rhode Island. So do feel free to email me, and I'd be happy to chat with you further.
Also, I just wanted to give a little plug that the framework that has been put forward in the clinical report from the various professional associations are the 6 core elements of healthcare transition. And a lot of these disease-specific groups have customized those tools for use. And those are available on our website at gottransition.org.
Okay, so one question I think could also be answered by Patience or Peggy is, I am a facilitator for youth with lupus, and what topics are best to discuss with them when discussing transition from their pediatric to adult rheumatologist?
Well, there are a lot of suggestions, certainly through the American College of Rheumatology. Also, we have a readiness assessment, and there are several out there that start with questions that young people should be thinking about as they're moving from a pediatric to adult healthcare system. I think self-advocacy is central in all of these questions. So you could look on our website and look for these readiness assessments, or go to rheumatology.org. They also talk about what you can do, particularly around lupus.
Okay, and here's another question for Lynn or Ava. What groups look at Title V the way you are for Medicaid?
So I'm not aware, I guess, of if there is kind of an equivalent group for Title V. So it looks like there may be some other responses in there that might in the chat about potential similar groups, but I'm not aware of any.
Okay, the next question. Even though you are focusing on Medicaid, what do you are you considering the implications that Medicaid, its MCOs, do change if it's primary, secondary, or even tertiary? The same issues can happen with secondary Medicaid and commercial primary insurance.
I want to make sure I'm understanding the question correctly, but if it's, I guess if Medicaid is your primary versus a secondary insurance, maybe is that, but this isn't something we specifically focused on in our work, but is certainly an interesting consideration of kind of the implications for transition planning.
I just want to also let the audience know that the level of work that this MACPAC team does is quite amazing, and just we're one chapter in their report and the other topics, just to give you some sense of all the things that they're balancing, was on access to residential behavioral treatment for children, access to Medicaid medications for opioid use disorder, understanding all-inclusive care for the elderly, and self-direction for home and community-based services. So I just want the audience to know that MACPAC has an enormous portfolio, and the fact that you have elevated transition is such a thrill for all of us. So I think if we could have a few 5 minutes to our time, I want to give it back to you all and maybe go to the last slide and thank Lynn and Ava and Holly so much for this outstanding webinar, which will be shared. The webinar and the report and slides will be shared with you following this and will be on our website. So thank you all.